In this class, we will talk about autoimmune hemolytic anemia. It is one kind of hemolysis caused by autoantibody, specially targeting red blood cell. According to the most active temperature of the antibody, it can be subclassified as warm antibody and cold antibody autoimmune hemolytic anemia, or it can be subclassified as idiopathic or secondary according to etiology. Once a red cell is coated by an autoantibody, it will be destroyed by one or more mechanisms. In most cases, the Fc portion of the antibody will be recognized by the Fc receptor of macrophages, and this will trigger erythrophagosis. Thus, destruction of red cells will take place wherever macrophages are abundant, such as spleen, liver, or bone marrow. This is called extravascular hemolysis. Mostly, only a portion of the red blood cell membrane was phagocytosed, producing a spherocyte. Less commonly, the entire red blood cell may be phagocytosed. The slow passage of red blood cells through the spleen fosters prolonged interaction between multiple IgG molecules and multiple Fc receptors in a patch of membrane of the phagocytic cell, enhancing phagocytic clearance. Spherocytes are less deformable than normal red blood cells and become trapped in splenic sinusoids, further extending the time during which phagocytosis can occur. So, the spleen is the predominant site of red cell destruction. Cytotoxic T cells in the spleen also carry Fc receptors and cause cell-mediated cytotoxicity of red blood cell. In some cases, the nature of the antibody is able to activate complement, such as IgM. As a result, a large amount of membrane attack complex will form, and the red cells may be destroyed directly. This is known as intravascular hemolysis. Warm antibody autoimmune hemolytic anemia is the most common type of autoimmune hemolytic anemia. About 50% cases have no inducing factors, that is, idiopathic. Others are usually secondary to lymphoproliferative disease, such as lymphoma, or autoimmune diseases, such as systematic lupus erythematosus. Viral infection and drugs, such as penicillin, cephalosporin, and mesodopa, can also lead to autoimmune hemolytic anemia. Clinical manifestations are various, depend on hemoglobin level, rate of decline, and other comorbidities. The antibody is almost always IgG. Red blood cells are phagocytized by macrophages, mostly in the spleen, so it is mostly extravascular hemolysis. Patients may have the symptoms of anemia, jaundice, and splenomegaly. 10 to 20% have immune thrombocytopenia, which is called Evans syndrome. Antiphospholipid antibody syndrome should be noticed if patients have thromboembolism, and the antiphospholipid antibody should be detected. Complete blood count is similar to classical hemolytic anemia, may find spherocytes, but less than hereditary spherocytosis. Reticulocytes is increased, and erythroid compensatory hyperplasia in bone marrow. Unconjugated bilirubin in blood is increased. Urobilinogen in urine is positive. LDH is increased. Coombs test is gold standard. More than 90% patients are positive. After washing the red blood cells, antibody firmly banded on red blood cell is detected by anti-IgG or C3 antibody. Positive test infers autoimmune hemolytic anemia. Diagnosis is based on hemolytic anemia and positive Coombs test. It should be noticed that there are also Coombs test negative autoimmune hemolytic anemia because of anti-human antibody specificity. We should search possible underlying diseases and excluding other hemolysis disease, such as hereditary spherocytosis. Treatments include underlying disease therapy and control hemolysis. Corticosteroid is the first choice for control hemolysis. Prednisone is mostly commonly used, usually begin from 1 to 1.5 mg per kilogram body weight. Hemoglobin generally starts to rise around 1 week if the treatment is effective. This is generally continued until the hemoglobin is over 10 mg per deciliter, which occurs in most patients within 2 to 3 weeks. After reaching 100 grams per liter, if the hemoglobin level has stabilized and markers of hemolysis are normal or clearly improving, a taper can be initiated. Reduce prednisone dose by 5 to 10 mg per week until the dose reaches 5 to 10 mg per day. Maintain it until total therapy lasts 3 to 6 months. If no response after 4 weeks of steroid, change into second-line therapy. Rituximab may be used as initial therapy in combination with glucocorticoids or added to glucocorticoids if the hemoglobin doesn't improve with glucocorticoids alone. Rituximab is an anti-CD20 monoclonal antibody that can selectively remove B cells, thereby decreasing autoantibody against red blood cells. Mostly, it is used as 375 mg per square meter of body surface area intravenously weekly for 4 weeks. Splenectomy is applied only when no response to steroid or steroid maintained dose more than 10 mg per day, or patients have contraindications to or intolerant to steroid. Other immunosuppressive agents may be effective, such as cyclophosphamide, azathioprine, and mycophenolate mofetil. They are indicated only after failure to steroid. Rituximab and splenectomy all have contraindication to splenectomy. For severe patients, danazol or high dose of immunoglobulin can be chosen. Red blood cell transfusion can only be given after saline washed. Cold antibody autoimmune hemolytic anemia include cold agglutinin syndrome and paroxysmal cold hemoglobinuria. Cold agglutinin syndrome is usually secondary to lymphoproliferative disease. Mycoplasma infection infectious mononucleosis, while paroxysmal cold hemoglobinuria is usually secondary to various infection or syphilis. Cold agglutinin syndrome is mostly chronic extravascular, occasionally intravascular, such as when having infection. Autoantibody is IgM. It occurs only in cold circumstances, can have cyanosis of end of limbs and anemia, mostly seen in old person. Cold agglutinin test is positive. Autoantibody IgM can be found on immunofixation. Coombs test C3 is positive. Paroxysmal cold hemoglobinuria. It is intravascular hemolysis caused by autoantibody and complement. Autoantibody is IgG, which is also called Donnas-Landsteiner antibody. Hemolysis occurs only in cold circumstances. Patients present with anemia and hemoglobinuria. Cold-warm hemolysis test, also called DR test, is positive. DR antibody can bind to red blood cells at 0 to 4 centigrade and fix the early components of complement. When returns to 37 centigrade, later components of complement are activated and leading to hemolysis. This is why hemolysis occurs after cold environments. Treatment of cold antibody autoimmune hemolytic anemia includes treatment of the underlying disease and keep warm. Steroids have no effect. Rituximab and immunosuppressive agents may be helpful. That's all. Thank you.